Hello everyone. In this module, we are going to be talking about atrial fibrillation and atrial flutter. First, let's start with atrial fibrillation. Atrial fibrillation is a form of cardiac arrhythmia. It results in an irregularly irregular pulse, and I have highlighted the words irregularly irregular because it's a classic feature of this disease. It can cause palpitations, fatigue, and dyspnea. We'll talk more about these later on, and it can be diagnosed by an ECG. Here are some causes of atrial fibrillation. We have ischemic heart disease, hypertension, thyrotoxicosis, rheumatic heart disease, and alcohol. This is also called holiday heart syndrome. That is, every time the person drinks alcohol, he or she develops atrial fibrillation. In the bottom ECG, you can see a sinus rhythm which has a P wave, a QRS complex, and a T wave. At the top is an EKG of a patient with atrial fibrillation. Notice that there are lots of bumps before a QRS complex. Below, there was a QRS complex after a P wave, but at the top, there are waves which are not organized with no distinctive P wave. These are called as fibrillatory waves. Also notice that the QRS complex, which represents a heartbeat, is occurring in an irregularly irregular pattern. Let me explain this. In the second ECG, the distance between any two QRS complex is constant, which means the heartbeat is regular. But above, you can see here the distance between these QRS complex is short and again short, but here the space is long, again followed by a short space and again a long space. So there is a form of irregularity with no any pattern of its own. That's why we call it irregularly irregular. Here is a full 12 lead EKG reading. Notice the waves between two QRS complex are wavy with absence of P wave. Here you can see the distance between two QRS complex are not the same. This absence of P wave with irregularly irregular pattern is considered that of atrial fibrillation. Here is another ECG. In this one, the heart rate is fast, but notice the space between two QRS complex is shorter here and larger here. So it's an irregularly irregular pattern. But here you can see there are little bumps between two QRS complex, and you might confuse them with the P wave. But these bumps are actually that of T waves. To clearly distinguish them, find two QRS complex with larger space between them, and here you can clearly see the T wave following the QRS complex. The P wave is not very distinctive. So the absent P wave with irregular pattern of QRS complex suggests atrial fibrillation. Now let's talk about what's happening in the atrial fibrillation in cellular level. Normally, the SA node generates waves of depolarization which passes through AV node followed by bundle of His, right and left bundle branches, Purkinje fibers, and finally reaches the ventricles. What happens in atrial fibrillation is that small segments of depolarization occurs all over the atria. So in other words, multiple areas in both right and left atria are depolarizing simultaneously, thus creating an irregular waves of depolarization. Some of these waves travel through the AV node and depolarize the ventricles, and these waves will generate a QRS complex in irregular pattern. So this explains why there is irregularly irregular pattern. Now let's see some types of atrial fibrillation. Paroxysmal atrial fibrillation is atrial fibrillation that comes and goes, usually occurring in hours. So it occurs in an intermittent fashion and there is a spontaneous conversion to sinus rhythm. Persistent type is the one which lasts for days or weeks and often requires electrical or chemical cardioversion to restore sinus rhythm. We'll talk about cardioversion later in this video. And then finally, permanent atrial fibrillation, as the name applies, is permanent and does not revert back to sinus rhythm. Atrial fibrillation presents with wide spectrum of symptoms. Many patients are asymptomatic and have a heart rate of less than 100 beats per minute. In these cases, atrial fibrillation is detected while doing routine ECG or when someone examines the pulse and finds that it is irregular. On the other hand, Patients can present with symptoms like palpitations, dyspnea, fatigue, and angina. And these patients often have heart rate of more than 100 beats per minute. The major reason behind why some patients with atrial fibrillation are asymptomatic with heart rate less than 100 beats per minute and some are symptomatic with heart rate more than 100 beats per minute is due to AV node refractory period. Once the AV node catches an impulse, it goes into refractory period, and during this refractory period, AV node cannot conduct any other impulses. So if the AV node is healthy and has a quick recovery time, then it can conduct many impulses, thus creating rapid heart rate. But if the AV node is slow and has a long refractory period, then the heart rate is slower. Atrial fibrillation can lead to a cardiomyopathy. This is caused by untreated rapid atrial fibrillation. The word rapid is highlighted because the heart rate should be rapid to cause this cardiomyopathy. In fact, it's called as tachycardia-induced cardiomyopathy. If the atrial fibrillation occurs for a long period of time, then the ejection fraction of the left ventricle will decrease, and this can lead to systolic heart failure. And as I mentioned before, many patients with atrial fibrillation are asymptomatic. So, heart failure could be the reason the patient might experience symptoms for the first time. In some patients with atrial fibrillation, the ventricular prefilling is eliminated because the atrium cannot contract properly and thus cannot push the blood into the ventricles effectively. This can be described as loss of atrial kick. Since the ventricles cannot be filled properly, the preload decreases and this can lead to low cardiac output and hypotension. This in particular affects people with aortic stenosis and diastolic heart failure because the cardiac output in these patients is mainly dependent on preload. Now, although atrial fibrillation presents with a range of symptoms, the disease itself is not very life-threatening. But what can be life-threatening in a patient with atrial fibrillation is formation of thrombus in left atrial appendage. Left atrial appendage is an outpouching in left atrium. It has a slower blood flow, and this blood flow becomes even slower in atrial fibrillation and thus increases the risk of thrombus formation. And what you are seeing on the screen is the thrombus that is formed in the left atrial appendage. This thrombus can break down and travel all the way up to brain to cause a stroke. It can go to gut and cause mesenteric ischemia, or it can go into spleen to cause splenic infarction. Now let's move on to the treatment section. When we think about treating atrial fibrillation, there are three options. The first one is controlling the heart rate. This is called rate control, and ideally we aim to bring the heart rate below 110 beats per minute. The second thing we treat is heart rhythm. This is called rhythm control, and this involves restoration of sinus rhythm. And the final treatment option is use of anticoagulants to prevent the risk of thrombus formation and stroke. When a patient with atrial fibrillation presents with a faster heart rate, like shown in this ECG, the first thing we do is administer drugs to slow down the heart rate and bring it more towards the normal. These drugs will not eliminate the arrhythmia, that is, atrial fibrillation will persist, but slowing down the heart rate makes patient feel much better because all those symptoms like palpitation and dyspnea that were making patient very uncomfortable were due to tachycardia. So when you slow down the heart rate, these symptoms will be gone. And the drugs that can be used are beta blockers like metoprolol, atenolol, that are beta-1 selective agents, calcium channel blockers like verapamil or diltiazem, and digoxin. The reason why we use these drugs is because they all slow down the AV node conduction. Now for many patients, controlling the heart rate is all that is required and they remain asymptomatic for rest of the period. But in some patients, even after slowing down the heart rate, the symptoms persist. And in these patients, we need to do what is known as rhythm control. The main aim of rhythm control is to restore normal sinus rhythm. And this involves doing a procedure called as cardioversion, which will convert atrial fibrillation to normal sinus rhythm. Cardioversion could be electrical cardioversion, where we use a machine called as defibrillator to deliver electrical shock to the chest, and this will restore the sinus rhythm. Or it could be chemical cardioversion, where antiarrhythmic medication is administered to restore the sinus rhythm, and often it is ibutilide, which is a class 3 antiarrhythmic. But nowadays it is less commonly used due to drug toxicity. And in addition to electrical or chemical cardioversion, we also administer antiarrhythmic medications before or after cardioversion to prevent the relapse of atrial fibrillation once the sinus rhythm is restored. And for this, we can use class 1 antiarrhythmics such as flecainide or propafenone, and class 3 antiarrhythmics such as amiodarone or sotalol. And the third option for treating atrial fibrillation is use of anticoagulants. These prevent the formation of thrombus and thus prevents stroke. The most commonly used drugs are aspirin and warfarin. Aspirin is less effective as compared to warfarin. Hence, it is only used if the risk of stroke is very low. So, it is important to calculate the risk of stroke in a patient with atrial fibrillation. For that, we have something called as Church-Vask score. C stands for congestive heart failure, which has a score of 1. H for hypertension with a score of 1. A stands for age more than or equal to 75 years, which has a score of 2. D for diabetes mellitus with a score of 1. S stands for history of prior stroke with a score of 2. V stands for vascular disease with a score of 1. A is for age between 65 and 75 years with a score of 1. And lastly, sex category, that is female, with a score of 1. If the total score is 0 or 1, then aspirin is used. And if the score is 2 or more than 2, then warfarin is used. Lastly, we're going to briefly talk about atrial flutter, which is another cardiac arrhythmia and has many similar symptoms and treatment to that of atrial fibrillation. The key difference between the two is seen in ECG. This is an ECG of a patient with atrial flutter. Notice the sawtooth patterns of waves between the two QRS complex. You can see them in every leads. These are called as flutter waves and are consistent with atrial flutter. What's happening in atrial flutter is different from what occurs in atrial fibrillation. We learned that in atrial fibrillation, there are multiple points of depolarization in the atria. These depolarizations are random and occur spontaneously. But in atrial flutter, the aberrant electrical waves are much more organized. There is usually a circuit in the right atrium where the electrical activity goes round and round through it. And each time an electrical activity completes one round, it generates one of those sawtooth flutter waves. And some of these waves are conducted through AV node to ventricles and create a QRS complex. And unlike in atrial fibrillation, the QRS complex in atrial flutter can occur in a regular rhythm. The symptoms and treatment of atrial flutter are pretty similar to that of atrial fibrillation. However, one treatment which is unique to atrial flutter is atrial flutter ablation. Since I told you that in atrial flutter there is a circuit in the right atrium through which the electrical activity moves round and round. In atrial flutter ablation, we use a catheter to burn a line of myocytes in the right atrium. What it does is that it breaks the circuit because the scar tissue won't be able to conduct the electrical impulse, and this will possibly eliminate the arrhythmia. So that's all about atrial fibrillation and atrial flutter. Thank you.